Have you ever thought about those global health challenges? The ones that seem to sort of fade away sometimes, but then, well, they just stubbornly stick around.
Yeah, despite all our best efforts, really.
Exactly. Diseases we kind of thought were on the way out, but they're still causing real problems worldwide, often for the people who can least afford it.
Hmm.
So today, we're doing a deep dive into one of those, tuberculosis, TB. It's ancient, isn't it? Been with us for millennia.
It really has.
And even though there's this big global strategy aiming to end it by 2035, it's still a huge challenge.
Absolutely. A formidable foe, as you say.
So we're going to unpack that global plan, the NTB strategy, and then really look at the specific hurdles, especially in countries like Malaysia that are, carrying an intermediate burden.
Right, not the highest burden, but still significant challenges.
Yeah, and we'll focus on some key complicating factors too, like the links with diabetes and migration.
Which are increasingly critical pieces of the puzzle.
Our insights today just, come from digging into a pretty detailed study group document.
Yeah.
So it gives us a really thorough, practical look at TB control, on the ground.
And what's really interesting about the global effort against TB is how they've tried to build this coherent framework, learning from what worked before, but also from the gaps.
Like the DOTS strategy.
Exactly. The END TB strategy, which WHO endorsed back in 2014, it definitely built on successes like DOTS. But critically, it was designed to tackle things DOTS couldn't fully fix.
Such as?
Things like drug-resistant TB, which is a huge problem, and co-infections like HIV, and maybe most importantly, the underlying social issues that, keep TB spreading in communities.
And the overall vision is, wow, it's incredibly ambitious, isn't it? A world free of TB, zero deaths, disease, and suffering due to TB. It's more than just medical.
It's absolutely humanitarian. And to get there, the targets are just as bold. We're talking a 95% reduction in TB deaths.
95%.
And a 90% cut in the number of new cases, the incidence, by 2035. That's compared to 2015 levels.
Okay.
But, and this is really key, it also aims for zero families facing catastrophic costs because of TB.
That's crucial, because the cost can be devastating, right? Even if treatment is technically free.
Precisely. It's this deep recognition that poverty and disease are completely intertwined. You can't end TB if getting treated pushes families into financial ruin.
Makes total sense. So, okay, to achieve this vision, what are the core principles? What's the foundation this whole strategy rests on?
Well, there are four main guiding principles. The first one is government stewardship and accountability, with monitoring and evaluation.
Right. So governments have to lead the charge.
Exactly. Countries have to own their national TB response.
Right.
It needs to be embedded in their main health strategies, linked up with things like universal health coverage.
So it's not just a side project.
Not at all. It requires clear leadership, consistent funding, and really transparent oversight, tracking progress. Malaysia is a good example here. Their Ministry of Health has a dedicated national strategic plan for TB running 2021-2030.
All right.
And it has specific annual targets for things like incidence and treatment success rates. That shows real government ownership.
Got it. So government commitment and measuring progress. What's principle number 2?
Second is building a strong coalition with civil society organizations and communities. This one's really vital. It's about shifting the mindset.
How so?
Patients aren't just people receiving treatment, they become real partners. It stresses that patients, their families, NGOs, local communities, they're all integral, not just receiving services, but helping plan, deliver, and monitor them.
So bringing everyone to the table.
Absolutely. Think about community health workers, peer support groups, TB champions within communities. They play such a crucial role in, say, breaking down stigma, helping people stick with treatment.
Like in Malaysia. Are they doing this?
Yeah. Malaysia actively engages NGOs, for example, to run awareness campaigns, especially reaching out to urban poor communities or migrant workers who can be really hard to connect with otherwise.
Sounds like it makes the whole effort more grounded, more community-driven. What else? What's the third principle?
Third is the protection and promotion of human rights, ethics, and equity. This is fundamental. It means TB services must respect patients' rights.
No discrimination.
Absolutely. Non-discrimination and deliberately targeting vulnerable populations. We have to actively work against the stigma that's so often attached to TB.
And focus on specific groups.
Yes. Groups like people living with HIV, prisoners, the elderly, people who might be missed or face extra barriers. A good example is prison TB screening programs you see in many countries.
Right.
They aim to find and treat TB, but crucially, while upholding inmates' basic right to health. It's this recognition, you see, that you can't fight a disease effectively if you're leaving people behind or making them scared to ask for help.
Makes sense. And the last one, the fourth principle.
That's the adaptation of the strategy and targets at country level with global collaboration. Basically, it admits there's no single magic bullet for TB.
No one size fits all.
Exactly. Strategies have to be tailored, adapted to each country's specific situation, its epidemiology, its health system. But importantly, this doesn't mean working in isolation.
Okay.
It encourages this global spirit of sharing knowledge, embracing new tech, trying out flexible care models, doing operational research to see what actually works best locally.
Can you give an example?
Sure. Malaysia, again, they've adopted rapid diagnostic tools like GenExpert pretty effectively, and they've adapted how they do contact tracing to fit the very different realities of, say, dense urban areas versus remote rural settings.
Right. Different approaches for different places.
Precisely.
Okay, so those four principles sort of define the philosophy, the how of the global approach. Now, how did that translate into actions? What are the actual operational pillars?
Right, the doing parts. There are 3 strategic pillars. Pillar 1 is integrated, patient-centered care and prevention. This is a really big shift in thinking.
How so?
Instead of just reacting when someone gets sick, it pushes for really aggressive early action and kind of wraparound support. Because we know TB treatment is long, it's complex.
So it's holistic.
Exactly. Not just about the drugs, but the whole person, the whole journey. It involves several key things. First, early diagnosis, universal drug susceptibility testing, DST, and systematic screening.
Okay, break that down.
It means finding cases quickly, testing everyone for drug resistance right away, that's the universal DST part, and actively screening people who are at high risk.
Using tools like GenExpert.
Yeah, rapid molecular tests like GenExpert are huge here. They speed things up massively. Malaysia, for example, systematically screens household contacts of known TB patients to catch any new infections early.
Makes sense. What else under Pillar 1?
Second is treatment of all TB cases, including drug-resistant TB, with comprehensive patient support. Every single patient, whether their TB is drug-sensitive or resistant, needs the right treatment and, crucially, consistent support to finish the whole course.
That support part sounds key, given how long treatment takes.
It's essential. Strategies like directly observed therapy, DOTS, or community-based care models help with this. In Malaysia, you actually have DOTS teams visiting remote villages to make sure people take their meds. For a 6 to 9 month regimen, that's a massive commitment, you know?
Wow, yeah. What else?
Third is collaborative TB-HIV activities and management of comorbidities. This is about linking TB programs with other vital health services. HIV is the classic example, but also increasingly other conditions like diabetes.
Right, you mentioned diabetes earlier.
Yeah. So this involves bidirectional screening. Basically, you screen TB patients for HIV and diabetes, and you screen HIV and diabetes patients for TB symptoms.
Closing the gaps.
Exactly. Malaysia, for instance, makes it a point to screen TB patients for both diabetes and HIV right when they're diagnosed.
Okay, and the last part of Pillar 1.
That's preventive treatment for high-risk persons and vaccination. This means treating latent TB infection, the sleeping form, to stop it becoming active disease, especially in high-risk groups. And of course, continuing BCG vaccination for babies.
Like for kids who've been exposed.
Yes. For example, children under 5 who are close contacts of someone with active TB are often given preventive therapy because their risk is much higher.
Got it. That's a really comprehensive first pillar. Very patient-focused. What's Pillar 2?
Pillar 2 is bold policies and supportive systems. This is about creating the right environment, the enabling conditions for TB control to actually work, tackling the broader stuff.
Okay, like what kind of stuff?
Well, first, political commitment with adequate resources. Governments have to genuinely prioritize TB. That means sufficient, sustained funding and policies that support the goals.
Money talks.
It certainly helps. Malaysia's national TB budget, for instance, supporting free treatment for all patients, that's absolutely critical for reducing financial barriers.
Right. What else falls under supportive systems?
Engagement of communities, civil society, and crucially, public and private care providers. This stresses working together across all sectors, even getting private clinics and pharmacies on board for proper notification and standardized treatment.
Public-private mix idea.
Exactly, often called PPM models, especially useful in urban areas where many people might seek private care first.
Okay.
Then there's universal health coverage policies and regulatory frameworks, making sure services are accessible and affordable for everyone. TB being a notifiable disease in Malaysia, for example, that ensures cases get reported centrally. This pillar also covers things like good infection control in hospitals.
Makes sense. Anything else?
Yes, social protection and poverty alleviation. This aims squarely at those indirect costs we talked about: transport, lost wages that often cause people to stop treatment.
Even if the drugs are free.
Right. Some states in Malaysia actually work with NGOs to give out travel vouchers for TB patients in rural areas. That directly tackles a non-medical financial barrier.
That's a really practical approach.
Yeah.
Okay, so pillar 1 is direct care. Pillar 2 is the supportive environment. That leaves pillar 3, must be about the future.
Spot on. Pillar 3 is intensified research and innovation. This is all about pushing the boundaries, constantly trying to find better ways to fight TB.
New tools, new approaches.
Exactly. First, the discovery, development, and rapid uptake of new tools. Think better, faster diagnostics, shorter, less toxic treatment regimens. That's a huge goal. And the holy grail, really, new and more effective vaccines.
We definitely need those.
Absolutely.
Yeah.
And countries need to adopt these innovations quickly when they become available. Malaysia, using GenExpert for rapid DST, is a good example of adopting new diagnostic tech.
And is there another part to the research pillar?
Yes, just as important is research to optimize implementation and impact. It's not just about inventing new stuff, but figuring out how to use what we have better in real-world settings.
Operational research?
Precisely. Local operational research to fine-tune interventions, develop new approaches tailored to local needs. Those studies in Kelantan, Malaysia, looking at TB diabetes co-management models. Perfect example. How do we best deliver integrated care in that specific context? So just to quickly wrap up Malaysia's position, its national TB control program really does try to align directly with this end TB strategy. The goals are clear: increase case detection, cut incidence and deaths, and hit high treatment success rates, ideally over 90%.
Okay, that sounds like a really solid, well thought out global plan. Meticulous even. But, the real world, it always throws curveballs, doesn't it?
Always.
So let's pivot now. Let's talk about the actual obstacles, the challenges countries face when they try to put this blueprint into practice, especially those intermediate burden countries like Malaysia, where the fight is still very much ongoing. What does this all mean when you're trying to implement it on the ground?
Yes. This is where the rubber really meets the road. And one of the biggest hurdles, honestly, is weak public awareness about TB.
People just don't know enough.
Often, yeah. Basic stuff, how it spreads, the symptoms, why finishing treatment is so incredibly important. This low health literacy leads to delays. People wait too long to seek help.
And maybe underreporting too.
Definitely. And poor adherence to treatment. In Malaysia, for instance, you still find myths like TB being hereditary, or just intense fear of social isolation if you get diagnosed.
Especially in certain communities.
Yeah, particularly in rural areas or among marginalized groups. That fear, it's a powerful barrier, stops people getting tested early.
If people are stopping treatment early, I imagine that causes a whole cascade of other problems.
Oh, absolutely. It leads directly to a high default rate, which hammers your cure rates. Patients stopping treatment before they're supposed to, it's a persistent, difficult problem.
Why do they stop?
Well, the treatment is long, right?
Yeah.
6, 9 months, sometimes longer for resistant forms. That's a huge ask. Plus, side effects can be tough. Stigma plays a massive role. Lack of support from family or employers.
And those indirect costs again.
Exactly. Even with free meds in Malaysia, if you can't afford the bus fare to the clinic or you lose wages taking time off work, that can be the breaking point, especially for the urban poor, indigenous communities, people in remote areas. Then there's the challenge of poor information management and research gaps. Good TB control needs good data, solid surveillance.
But that's often lacking.
It can be fragmented data systems, weak monitoring. It means you might not be detecting all the cases, or you might not be allocating resources effectively. In Malaysia, for example, underreporting from the private sector is a known issue.
So cases get treated but don't make it into the national count.
Sometimes, yeah, which affects the overall picture, the planning. And we definitely need more operational research, especially on those co-infections like TB diabetes, and on how best to reach migrant populations. We need tailored interventions.
Okay, speaking of migrants, I could imagine TB among foreign migrant workers must present a whole unique set of difficulties.
It's a really significant one. Migrants often come from countries with a high TB burden. They might arrive with latent or active TB.
And their living conditions.
Often challenging. Overcrowded, poorly ventilated settings. Plus, they face major barriers to getting healthcare language issues, fear of getting deported if they interact with authorities, maybe no insurance.
That sounds incredibly tough.
It is. In Malaysia, foreign workers make up a noticeable chunk of TB cases, maybe 10–12% each year. And sometimes employers might try to avoid screening them to save money. Workers themselves might avoid public clinics, worried about their job security. It creates this awful cycle of delayed diagnosis and potential transmission. Another huge factor is the high burden of comorbidities. We keep coming back to this, but it's critical, especially diabetes, mellitus, HIV/AIDS, and smoking.
Remind us why diabetes is such a big issue.
Diabetes basically triples your risk of developing active TB, and it makes treatment outcomes much worse. HIV, of course, dramatically increases vulnerability and mortality. Smoking damages lung immunity, makes you more susceptible.
And Malaysia has high rates of these.
Particularly diabetes. It's around 15% nationwide, but in some areas, like Kelantan, it can be up to 27%. That really fuels a significant TB diabetes co-infection problem.
But the screening isn't always happening.
That bidirectional screening, testing TB patients for diabetes and vice versa, it isn't uniformly implemented yet. So cases are definitely being missed. Opportunities for better management are lost.
So it's not just one disease. It's this complex web of health issues.
Yeah.
And then looming over all of this is the threat of resistance, right? Drug-resistant strains.
Exactly. The constant threat of drug resistance, MDR-TB, multi-drug resistant, and XDR-TB, extensively drug resistant, is a really serious concern.
How does that happen?
It mainly comes from incomplete or improper treatment, people not finishing their meds or getting the wrong regimen. Poor adherence is a big driver.
I mean, treating these resistant forms is much harder.
Much harder, longer treatment, usually years, more toxic drugs with worse side effects, far more expensive, and sadly, significantly lower success rates. In Malaysia, maybe 1–2% of cases are MDR-TB, but even that small percentage puts immense strain on the labs needing to do rapid DST and on the whole healthcare system. And we can't forget stigma and discrimination. It's still a massive barrier, often kind of invisible, but incredibly powerful.
How does it act as a barrier?
It just discourages people, stops them getting tested, makes them reluctant to continue treatment. They might hide their illness, which leads to more transmission. In Malaysia, you see certain groups, indigenous communities, prisoners, migrants facing this double stigma, compounding their fears and leading to really dangerous delays in getting care. We also have to factor in an aging society. As populations get older worldwide, people's immune systems naturally weaken. This increases the risk of latent TB, that sleeping infection, reactivating.
And older people might present differently.
Yeah, they might have atypical symptoms, making TB harder to diagnose quickly. This can lead to late diagnosis and continued spread, even in places like aged care facilities. And zooming out globally again, migration and cross-border spread is a constant factor. The movement of people, especially from high-burden countries, means TB gets imported, including drug-resistant strains.
Compounded by living conditions again.
Often, yes.
Yeah.
Migrants might live in crowded settings, lack health insurance, fear deportation, all contributing to underdiagnosis and treatment default. Malaysia employs a lot of migrant workers from high TB countries, so delayed case detection among them is a persistent challenge for the health system. The large, often unregulated private sector adds another layer of complexity. If private doctors or pharmacies aren't properly linked into the national TB program, what happens?
Cases get missed or treated improperly.
Both. Misdiagnosis, incorrect treatment regimens, or simply not reporting the case to the national registry. This allows transmission to continue silently in the community. Malaysia has expanded its public-private mix efforts, but challenges remain in getting consistent notification and ensuring patients complete the full treatment course. And finally, there are practical challenges around laboratory quality and MDR-TB management. You need accurate, timely diagnostics, right? But intermediate burden countries might face gaps.
Like what kind of gaps?
Issues with quality control in labs, unreliable capacity to do universal drug susceptibility testing for everyone diagnosed. In Malaysia, while they have GenExpert machines, ensuring they're available everywhere they're needed, with consistent supplies, especially in remote areas, can still be difficult. But despite all these hurdles, it's important to remember that intermediate burden countries often have real advantages that can be strengthened. Well, they usually have established health systems, trained healthcare workers, existing insurance schemes sometimes. Malaysia's free TB treatment, for instance, is a huge advantage. It significantly cuts financial barriers, although, as we've said, Those indirect costs still need more attention for the most vulnerable people.
Right. It's clear the global strategy is a fantastic roadmap, but navigating the actual terrain is full of potholes and detours.
Hmm.
And when we talk complexities, gosh, nothing seems more complex right now than that growing intersection between TB and another global giant, type 2 diabetes.
Hmm.
You mentioned comorbidities earlier. Why is this specific link, TB and diabetes, becoming so absolutely critical, especially in low-middle income countries?
It's a really crucial question, and the answer is, well, multifaceted. The TB diabetes link is becoming central to public health strategy now. Firstly, and most starkly, people with diabetes have a significantly higher risk of getting active TB.
How much higher?
About triple the risk, 3 times more likely. And diabetes that's poorly controlled. It actively fuels the TB epidemic because it impairs the body's immune response. Globally, it's estimated that something like 15% of all current TB cases are actually attributable to diabetes.
15%, that's huge.
It's a staggering number. And secondly, it's not just about getting TB, it's about what happens next. TB patients who also have diabetes generally have worse TB outcomes.
Worse in what way?
They often have delayed sputum conversion. That means it takes longer for the TB bacteria to clear from their lungs, so they remain infectious for longer. They also have higher rates of relapse after finishing treatment, higher rates of treatment failure, and sadly, a higher risk of death.
Why? What does diabetes do?
Diabetes causes specific changes in the immune system. High blood sugar, for example, can impair how well key immune cells, like macrophages, function cells that are critical for fighting off the TB bacteria.
Okay, so they're clearly deeply connected. Why aren't we doing a better job managing them together then? What are the big roadblocks?
There are several, unfortunately, starting right at the beginning with diagnostic challenges. TB symptoms can sometimes be masked or look different in people with diabetes, making it harder to spot.
Atypical presentation.
Exactly. And frankly, there's still limited evidence on which tests work best for diagnosing TB in diabetics or for picking up diabetes in TB patients. And maybe the biggest issue here is just low awareness and poor uptake of what we call bidirectional screening.
That idea of testing for both.
Yes, testing all TB patients for diabetes when they're diagnosed and screening all diabetes patients regularly for TB symptoms, maybe using symptom questionnaires or chest x-rays. It sounds simple, but it doesn't happen consistently.
So what's the strategy to fix that?
We need to make routine bidirectional screening the standard of care, especially in high-burden settings. Develop clear, standardized protocols. Invest in practical tools like point-of-care HbA1c machines that can test blood sugar easily right there in the TB clinic. And critically, we need more research to figure out the best, most cost-effective testing algorithms.
Okay, diagnosis is one hurdle. I imagine trying to treat both diseases at the same time must be incredibly complex too.
Oh, absolutely. That's the next major challenge, treatment complexity. There can be significant drug interactions. Rifampicin, which is a cornerstone TB drug, can actually make many common oral diabetes medications less effective.
That sounds dangerous.
It can be, leading to poor blood sugar control. Diabetes itself can also change how the body processes the TB drugs, affect their metabolism, their levels in the body. And ironically, some TB drug side effects can actually make blood sugar control worse.
So it's a vicious cycle.
It can be. Add to that the fact that these patients are often on multiple medications already, polypharmacy, and sticking to the complex regimen becomes a real challenge. Adherence suffers.
So how do we manage that complexity?
It requires really strong clinical guidelines for co-management, and crucially, using interdisciplinary teams, TB specialists, physicians managing diabetes, dietitians, pharmacists, all working together. Individualized diabetes plans are key.
Maybe switching medications.
Sometimes, yes. For instance, switching a patient to insulin during their TB treatment might be necessary for better control. Regular monitoring of both blood sugar and potentially TB drug levels is vital. And wherever possible, simplifying the overall drug regimen helps. Another huge issue is the lack of integrated care. Historically, TB and diabetes programs have operated in completely separate silos.
Different clinics, different doctors.
Often, yes. With poor coordination and referral systems between them, healthcare workers might be experts in one disease but lack the specific training to manage both together. This creates gaps. Patients fall through the cracks. The solution really lies in truly integrating services, especially at the primary healthcare level, maybe co-locating TB and diabetes clinics using shared electronic health records so everyone sees the full picture.
And training staff.
Absolutely. Cross-training healthcare workers is essential. We also need robust referral pathways. And honestly, we can learn a lot from how TB and HIV services were integrated. They faced very similar challenges of siloed care initially. Then there are the unavoidable health system limitations, things like inadequate infrastructure, not enough trained staff, or limited availability and affordability of diabetes supplies like test strips or insulin, practical on-the-ground barriers.
What can be done about those?
Well, TB diabetes co-management needs to be explicitly written into national health plans and budgets. We need dedicated, secure funding. We need to strengthen the supply chains for both TB and diabetes medications and supplies, and develop better monitoring tools specifically designed to track how well comorbidity care is working. We also face patient-level barriers. Patients themselves might not know about the link between TB and diabetes. There's still the stigma around TB we discussed, and often underlying lifestyle risk factors, diet, exercise, smoking, contribute to both conditions.
So how do you address those?
Through targeted health education, explaining the TB-diabetes connection clearly, peer support groups can be really powerful, community-based interventions. Using technology, like mHealth tools, simple SMS reminders for appointments or medication, and offering culturally appropriate lifestyle modification programs. And finally, underpinning a lot of this is a lack of research and evidence. There are still too few studies looking at the long-term outcomes of people with both TB and diabetes, or figuring out the cost-effectiveness of different screening strategies or integrated care models.
So we're still flying blind in some
To
areas.
some extent, yes, we're operating with some unknowns,
Yeah.
which really highlights the critical need for more research, particularly operational and implementation research.
What kind of research specifically?
Things like refining screening algorithms, understanding the pharmacokinetics, how TB drugs behave in the bodies of people with diabetes, evaluating different models of integrated care to see what works best where and for whom. Collaboration between national programs, academic institutions, NGOs, that's key to getting these pilot programs and evaluations done. Essentially, for every challenge in TB diabetes, there is a strategic path forward, but it requires real focus and dedicated effort.
We've talked quite a bit about social determinants in vulnerable groups, and few populations seem to face more compounding issues than immigrants and refugees, which brings us to our next really significant challenge. What does this whole TB picture mean for people navigating migration, one of the most vulnerable groups in our global community?
Right. Migration, especially from countries where TB is still very common, poses some really significant challenges for TB control, both epidemiologically and programmatically, in the countries receiving migrants.
Why is that?
It's largely down to the social vulnerabilities migrants often face, sometimes difficult living conditions, and just inherent barriers to accessing healthcare in a new country. One major issue is the direct impact on TB epidemiology. Migration can sustain TB transmission or even cause incidence rates to rise in countries that otherwise have low levels of TB. It can create these pockets of higher transmission, particularly in settings like overcrowded refugee camps or worker hostels.
You see that in Europe.
Yeah, it's quite striking. In some UEA countries, something like 30 to 50% of all TB cases reported are actually among people who were born outside the country. This points to a disproportionate TB burden among migrants. They generally have a higher prevalence of both latent TB, that's sleeping infection, and active TB disease.
Why is that? Exposure back home.
That's a big part of it, yes, exposure in their country of origin, but also poor living conditions during the migration journey itself, and then limited access to preventative care or early treatment once they arrive. And importantly, most of the active TB we see in migrants in low-burden countries isn't from recent infection in the new country. It's usually due to the reactivation of latent TB infection, LTBI, that they acquired years ago.
The infection wakes up.
Exactly. That period right after arrival, the first 2 to 5 years, seems to be a particularly high-risk time for reactivation. And triggers can include things like malnutrition, developing HIV, high levels of stress, maybe substance abuse.
Gosh, it paints a really stark picture, doesn't it? Trying to navigate a new country, maybe a new language, and then facing a diagnosis like TB, which could threaten your livelihood, your legal status. The vulnerability is just immense.
It really is. And this leads to major TB control challenges specifically within these populations. Delayed diagnosis is common, delayed treatment too. Why? Language barriers are huge, stigma and discrimination, again, lack of health insurance or proper legal documents, and a very real fear of deportation if they engage with health
And
services.
the consequence.
It leads to ongoing transmission within communities and often worse clinical outcomes for the individuals themselves, not just for them, but for public health overall. Migrants also frequently face difficult social determinants and vulnerability. We're talking poverty, overcrowded housing, poor nutrition, sometimes lack of clean water or sanitation, and often higher rates of HIV co-infection. All these factors increase TB risk and make treatment much harder. And finally, there are practical screening and prevention challenges. Many low-burden countries do screen migrants for TB, especially upon arrival, but the policies can be inconsistent between countries or even within them. Follow-up after screening might be poor, and again, stigma can lead people to actively avoid screening services, which undermines the whole effort. So, okay, those are the challenges. How do we overcome them? What are the strategies?
Yeah, what can actually be done?
Well, several things are crucial. For migrants coming from high TB burden countries, implementing systematic pre-entry and/or post-arrival TB screening for those considered high risk is a key strategy. For the issue of LTBI reactivation, offering preventive therapy to those with latent infection is vital after carefully weighing the risks and benefits for each individual.
What about access to care?
To tackle poor access, the key is ensuring free, culturally sensitive TB services are available to everyone, regardless of their migration status, and really investing in training health workers in cultural competence.
On the language barriers.
Using professional interpreters is non-negotiable, providing translated health materials, and employing multilingual community health workers who come from the migrant communities themselves that can be incredibly effective in building trust.
What about that fear of deportation? That seems like a huge barrier.
It is. Here, strong confidentiality protections are essential. And critically, establishing clear firewalls between immigration enforcement and public health services. People need to know that seeking health care won't automatically lead to deportation. Active anti-stigma campaigns targeting both the general population and healthcare providers are also needed.
What about living conditions?
For overcrowded living conditions, advocating for better housing policies is important, alongside conducting routine TB screening in known high-risk environments like shelters or hostels. For treatment adherence issues, things like directly observed therapy, DOT, can still be useful, but also newer approaches like digital adherence technologies, smart pill boxes, video DOT, and again, that support from community health workers is key.
You mentioned inconsistent policies.
Yeah, addressing policy inconsistency requires better regional collaboration, aiming for more harmonized policies on screening and treatment across different countries. And finally, for the perceived economic burden on health systems, the focus should be on implementing the most cost-effective interventions first, like treating active TB and targeted LTBI treatment, and seeking support from global health partners where needed. Beyond these specific strategies, there are broader recommendations, things like integrating TB services properly into overall migrant health programs, collecting better data specifically on TB in migrant populations so we understand the problem better, ensuring policies are truly equity-based and separate public health actions from immigration control, and, crucially, actively engaging migrant and refugee communities themselves in designing and delivering TB services. That builds trust and improves uptake. Ultimately, yes, the challenges are significant, but they can be managed effectively with strategies that are targeted, evidence-based, and importantly, compassionate, balancing disease control with upholding basic human rights and dignity.
Wow. What an incredibly illuminating deep dive today. We've really covered a vast amount of ground, haven't we? Starting with that comprehensive global vision, the NTB strategy, and then really digging into the profound, interconnected challenges that play out on the ground. It's just so striking how everything is linked from government accountability and global migration flows right down to individual patient journeys and these complex comorbidities like diabetes, all tangled up in the fight against this really persistent disease.
It really is. And I think what this deep dive shows so clearly is the absolute necessity of blending everything, the medical interventions, yes, but also the social and the structural ones if we're truly serious about ending TB as a public health threat by 2035.
It takes everything working together.
Absolutely. It requires that sustained political will we talked about. It requires empowering communities, really making them part of the solution, ensuring care is equitable, reaching everyone, and that constant drive for innovation and research to stay ahead of the challenges.
So thinking about everything we've discussed, those ambitious goals, the systemic hurdles, the deeply human aspects of stigma, migration, comorbidity. What stands out to you, listening in, about just how intertwined global health challenges truly are? And perhaps how much of a difference these kinds of compassionate, integrated approaches like the ones outlined in the NTB strategy could potentially make as we try to tackle other complex global issues in the future. Something to think about.